Hello, my name is Dr. Mark Socinski. I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. Welcome to this module on management of patients with unresectable stage 3 non-small cell lung cancer who have not progressed after concurrent chemoradiation. The presentation today is supported by AstraZeneca. This presentation is intended to provide educational information on the management of patients with unresectable stage 3 non-small cell lung cancer who have not progressed after concurrent chemoradiation. The presentation does not discuss or promote any investigational or approved drugs and does not refer to drugs by their brand name or commercial entities. The program is not a CME program. We will start with a case. This is the case involving management of stage 3C, non-small cell after concurrent chemoradiotherapy. Patient presented with cough, shortness of breath, chest pain, and weight loss. He was a 47-year-old gentleman, former smoker. Employed full-time. His performance status was said to be an ECOG 0. He doesn't have much in the way of past history. And you can see, I mentioned his presentation symptoms. On examination, the patient was found to have a palpable supraclavicular lymph node. Further workup included a CT-guided biopsy of the positive supraclavicular lymph node that was palpated at the time of initial examination. This showed a non-squamous non-small cell lung cancer, had the appropriate molecular testing done and did not show the presence of an oncogenic driver. PD-L1 expression was 5%. We're told a brain MRI is negative in this patient. The PET scan did show the 6-centimeter mass in the upper right lobe, as well as involvement of right hilar mediastinal, as well as the supraclavicular node. And I mentioned the previous biopsy. The PET scan also did show N3 disease on the contralateral side. The patient's treatment consisted of concurrent chemoradiotherapy, in this case using cisplatin etoposide and 60 gray of radiotherapy. The patient did have a disease response as noted in the table to the right. This slide summarizes the options or summary of the NCCN clinical practice guidelines for the consolidation immunotherapy as an option for unresectable stage 3 non-small cell lung cancer after concurrent chemoradiotherapy. And you see to the left in the stage 3A, 3B, and 3C that in the unresectable population after definitive concurrent chemoradiotherapy, consolidation immunotherapy is recommended by the NCCN guidelines. The time to initiation of consolidation immunotherapy following concurrent chemoradiotherapy, some guidance is provided here. Obviously, eligibility requires demonstration of no evidence of disease progression. A chest CT should be performed as soon as feasible, and certainly within 42 days of completing concurrent chemoradiotherapy. Consolidation immunotherapy is recommended to begin within 42 days or 6 weeks after the end of concurrent chemoradiation, and this is according to ESMO guidelines. Now, concurrent chemoradiotherapy may generate a tumor-specific immune response that over time can lessen. We know that concurrent chemoradiotherapy may shift the tumor microenvironment to a more immunostimulatory situation by promoting infiltration of T cells. We also know that during this process that upregulation of PD-L1 serves to kind of silence this immune response that may be attempted by the host to generate against the tumor. And again, this may lessen over time, which is demonstrated in the slide here. Now, going back to our case, this patient is considered for consolidation immunotherapy, initiates treatment. Patient does experience about 12 weeks into treatment some respiratory symptoms in the form of shortness of breath and cough. There was a suspicion by the multidisciplinary team of an immune-mediated pneumonitis. Now, it's important to understand the spectrum of immune-mediated adverse events. You can see here shown that pretty much any organ system in the body may experience in immune-mediated adverse events. Some of the more common ones being the thyroid gland, the lungs, the liver, the GI tract, the skin, and other endocrine organs. Less frequent immune-mediated adverse events would include neurologic syndromes, renal disorders, hematologic syndromes, cardiac or ocular disorders, fortunately being less common. Now, it's important to be aware of the signs and symptoms of immune-mediated pneumonitis. They're not specific to this disease. Dyspnea, cough were this patient's problem, but you can see listed to the left: fever, chest pain, wheezing, reduced exercise tolerance, fatigue. Again, relatively nonspecific symptoms shown here. Objective symptoms, there can be inspiratory crackles on examination, altered oxygen saturation by pulse oximetry, as well as radiographic changes. And obviously, complete evaluation of these patients at the time of early symptom development is critically important. Now, the diagnosis of immune-mediated pneumonitis is in many ways a diagnosis of exclusion. There are a number of other things to consider. They're shown to the left: a concurrent pneumonia, lymphangitic spread, pulmonary emboli, pulmonary edema. These sorts of things should be excluded. CT scans can be useful. Sometimes bronchoscopic evaluation or pulmonary function testing can be helpful in making the diagnosis. But again, it's primarily a diagnosis of exclusion. Now, the management is shown here. Obviously, we grade it. Grade 1 is radiographic changes only. Grade 2 is mild to moderate new symptoms. And grade 3 or 4 is when it progresses to severe or life-threatening symptoms that require hospitalization. It's important to characterize the pneumonitis as best as possible. It's important to have a low threshold for initiating steroids for grade 2 or overly symptomatic disease. Really, guideline recommendations on the management are presented in this slide. Dose modifications and adverse event management should be determined in accordance with the applicable product label and the clinical judgment of the treating healthcare professional. The importance of steroid tapering is summarized here. Obviously, once an immune-mediated adverse event has resolved to grade 1 or less, steroids should be tapered slowly. Abrupt stopping or tapering too quickly may result in a flare. And the duration of this really depends on the dose, duration, and severity of the immune-mediated adverse events, as well as the patient's other medical considerations. Patients need to be monitored closely during steroid tapering, and emphasize the importance of following the proper discontinuation instructions to avoid recurrence of their immune-mediated adverse event. Steroid refractory cases do occur, and they may require other immunosuppressive therapies such as infliximab or mycophenolate shown here. There are some general guidelines here. In the case of our patient here, grade 3 or 4 pneumonitis, if no improvement after 48 hours, you may add infliximab or mycophenolate to the steroids to help ameliorate the symptoms. Our case here shows that the patient was felt to have grade 2 pneumonitis, and this was based on the CT scan findings as noted here. Bronchoscopy did not document infection or cancer. In pulmonary function test, ruled out obstructive lung disease. So the empiric diagnosis of grade 2 immune-mediated pneumonitis was made. The patient did improve. In the IO management at that time was withheld, and proper corticosteroid treatment was given with prednisone at 1 milligram per kilogram in this particular case. So in summary, chemoradiotherapy may generate tumor-specific immune responses that lessen over time. Consolidation immunotherapy is an option for patients with stage 3 non-resectable or unresectable disease, assuming they have not progressed after chemoradiotherapy. Among immune-mediated adverse events associated with immunotherapy, pneumonitis is common and can be life-threatening. It's key that early recognition of key signs and symptoms is critical because the radiographic presentation of pneumonitis may be clinically asymptomatic. The diagnosis is primarily one of exclusion of other etiologies, And management is generally by the use of steroids, as we've reviewed.